Hello everyone, I'm Anthony Chan, and I am delighted to welcome you to the 7th lecture in my comprehensive lecture series on essential medical liver pathology, designed specifically for trainees and pathologists who have an interest in liver pathology. Throughout our previous lectures, we have explored a wide range of significant pathological changes and histological patterns that are observed in liver pathology. In this final lecture, we will be addressing the intriguing and often challenging I don't know category, which encompasses cases that are difficult to diagnose with certainty. Common histological patterns under these 4 major categories of liver injuries have already been discussed. At times, we come across instances that defy categorization into any of the established histological patterns. These cases lack a distinct histological pattern or discernible pathological hallmarks, making it challenging to arrive at a conclusive diagnosis based solely on the histological findings. I group these perplexing cases under the umbrella term I don't know. One of the patterns within this category is the nearly normal liver pattern. This term applies to liver biopsies that exhibit an absence of conspicuous histological abnormalities. However, certain minimal, non-specific changes are permissible under this diagnostic pattern, such as macrovesicular steatosis affecting less than 5% of the liver tissue, focal minimal inflammation within the portal tracts without evidence of interface hepatitis, or rare occurrences of steroid-laden macrophages. Despite these minor deviations, the overall histological picture remains largely unremarkable, leading to the classification of nearly normal liver pattern. Before diagnosing a nearly normal liver pattern, it is essential to rule out certain pathological changes that may be very subtle and easily missed in H&E sections. For instance, nodular regenerative hyperplasia should be excluded by examining the biopsy at low magnification to detect any vague hepatocellular nodulation. Portal vascular abnormalities linked to portal sinusoidal vascular disorder can be patchy and subtle, necessitating careful examination if the patient presents with portal hypertension. Amyloid deposits in portal vessels and portal tracts also require meticulous inspection. For further details, refer to the previous lecture on portal sinusoidal vascular disorder and nodular regenerative hyperplasia. We need to carefully rule out subtle deposits in hepatocytes such as alpha-1 antitrypsin, iron, and pseudoground glass inclusions. Additionally, we should consider glycogenic hepatopathy, which is characterized by significant enlargement of hepatocytes with cytoplasmic clearing due to excessive glycogen accumulation. This condition often presents with prominent hepatocyte cell membranes and markedly compressed sinusoids, producing a mosaic or plant-like morphology. Glycogenic hepatopathy is associated with glycogen storage disease, type 1 diabetes, and occasionally urea cycle defects. Microvesicular steatosis also needs attention, as the tiny fat droplets can be easily overlooked, appearing as clear cytoplasm. Lastly, it's important to pay attention to sinusoidal amyloidosis, iron deposits in Kupffer cells, and stellate cell hyperplasia. Stellate cell hyperplasia is particularly associated with hypervitaminosis A. A comprehensive study on the nearly normal liver histological pattern was conducted by colleagues at Johns Hopkins Hospital and the Mayo Clinic. Their research revealed that the frequency of encountering nearly normal or almost normal liver biopsies was 0.6% and 3.7% of all liver biopsies at these 2 institutions. A total of 97 liver biopsies from unique patients were included in their study after excluding those with incomplete clinical information. Notably, the most common indications prompting these biopsies were either elevated liver biochemistry results or clinical evidence of portal hypertension. After analyzing the clinical and laboratory data, including patient follow-up, a likely etiology for the clinical liver abnormalities was identified in 72% of patients. Hence, 28% remained unknown. The known etiologies were categorized into 8 broad categories. The 5 most frequent final diagnoses among the patients were systemic autoimmune inflammatory conditions 18%, vascular diseases 13%, metabolic syndrome 11%, drug reactions 8%, and gastrointestinal inflammatory conditions 8%. After a follow-up period of at least 1 year, 7 patients eventually developed confirmed chronic liver diseases, which included autoimmune hepatitis, primary biliary cholangitis, and cryptogenic cirrhosis. Among patients with a follow-up of more than 1 year, almost half of them had normalized liver biochemistry, whereas the remaining had persistent deranged liver biochemistry. In summary, a nearly normal liver pattern. refers to a specimen that appears largely unremarkable or exhibits only minor, non-specific histological changes. This occurs even when the patient has abnormal liver enzyme levels or other clinical indications that warrant the biopsy. It is crucial to correlate the clinical and pathological findings and ensure proper follow-up to determine the underlying cause. However, in at least 1/4 of cases, a definitive diagnosis is not reached. The non-specific reactive hepatitis pattern resembles the nearly normal liver pattern, but with slightly more pronounced necroinflammatory activity. The term non-specific reactive hepatitis was first introduced by Schaffner and Popper in 1959. They described it as a collection of abnormal liver biopsy findings, including ductular proliferation, inflammation, necrosis, and regeneration, observed in elderly or infirm patients without acute liver disease. This pattern was considered a non-specific liver response to various systemic diseases affecting the liver secondarily, resolving hepatitis, recent febrile illness, or inflammation in the splanchnic bed. In my view, this diagnostic pattern serves as a diagnosis of exclusion made after ruling out any acute hepatitis, resolving acute hepatitis, and chronic liver disease. Although comprehensive data is limited in the literature, the underlying causes are likely similar to those of the nearly normal liver pattern. Cryptogenic cirrhosis is a type of cirrhosis where the cause of liver damage remains unknown despite extensive clinical, laboratory, and histological assessments. Liver biopsies in cryptogenic cirrhosis exhibit typical cirrhotic features such as diffuse regenerative nodules, bridging fibrosis, and parenchymal extinction. However, they do not display the specific histological characteristics that would indicate a particular underlying liver condition, such as viral hepatitis, steatotic liver disease, autoimmune hepatitis, or chronic cholestatic disease. In a recent study of a nationwide cohort in the United States involving nearly 630,000 cirrhotic patients, 5.5% were classified as having cryptogenic cirrhosis. Notably, the incidence of cryptogenic cirrhosis increased from 5.3% in the period from 2003 to 2013 to 5.9% from 2014 to 2021, despite advancements in diagnostic techniques. The 5-year overall survival rate for cryptogenic cirrhosis was 58%, the lowest among all cirrhosis causes. Multivariable analysis revealed that cryptogenic cirrhosis was linked to a 1.5 times higher risk of mortality compared to untreated hepatitis C. Patients with cryptogenic cirrhosis often do not undergo routine monitoring, including hepatocellular carcinoma surveillance, as recommended for cirrhosis. As a result, they may present with more advanced diseases and are likely to have poorer survival outcomes. Burnt-out metabolic dysfunction-associated steatohepatitis MASH is considered a major cause of cryptogenic cirrhosis. As MASH progresses to advanced fibrosis, steatosis may resolve and affect less than 5% of hepatocytes. Identifying residual ballooning degeneration, Mallory-Denk bodies, and pericellular fibrosis, along with clinical evidence of metabolic risk factors, aids in diagnosing burnt-out MASH cirrhosis. Undiagnosed autoimmune hepatitis, hidden excessive alcohol consumption, and rare metabolic disorders are also potential causes of cryptogenic cirrhosis. Certain clinical pathological features should not be overinterpreted when managing a case of cryptogenic cirrhosis. For example, elevation of serum immunoglobulin G is often associated with autoimmune hepatitis and may lead to suspicion of this condition. However, elevated IgG levels can also be observed in cirrhosis resulting from other causes. Therefore, it is crucial to consider the broader clinical and histological context and not rely solely on this feature to make a definitive diagnosis. Similarly, grade 1 or 2 iron overload in both parenchymal and mesenchymal patterns is common in chronic liver disease with advanced fibrosis and cirrhosis and does not indicate hereditary hemochromatosis as the underlying cause. Mild copper-associated protein deposition is also frequently found in cirrhosis, but its presence alone does not suggest chronic cholestatic disease or Wilson disease. Additionally, alpha-1 antitrypsin globules can commonly appear in cirrhosis of any etiology. That's fantastic. We've addressed the difficult I don't know category, which involves cases that are hard to diagnose with certainty. Before wrapping up this lecture, I'd like to offer some personal practical advice or tips. The decision to review clinical and laboratory data before examining pathology slides is purely a matter of personal preference. Reviewing this data beforehand offers several significant advantages when examining pathology slides. It provides essential context for interpreting findings, guides the examination toward the most relevant features, and ultimately enhances diagnostic accuracy. This approach also facilitates a better correlation between the clinical picture and the pathological findings. However, it's important to recognize potential drawbacks, such as the risk of introducing bias or overlooking unexpected findings that may not align with the clinical context. In some cases, this could compromise the objectivity of the slide examination. Interestingly, I use both approaches in different settings. In my daily diagnostic work, I typically review the clinical and laboratory data first to expedite the process. However, during teaching sessions with fellows, I often use a blind approach where we examine the slides without any prior clinical information. Regardless of the chosen approach, the key is to always strive for objectivity and conduct a thorough, systematic examination of the slides. While I believe you are all familiar with interpreting liver biochemistry, I'd like to offer a gentle reminder. Firstly, although albumin and bilirubin provide valuable insights into liver function, INR is the most reliable indicator of liver failure due to its sensitivity to changes in liver synthetic function and its inclusion in the model for end-stage liver disease MELD. Secondly, while bilirubin levels are elevated in chronic cholestatic and biliary diseases, it is unusual for bilirubin to be elevated in the early stages of PBC and PSC. Thirdly, an AST to ALT ratio greater than 2 is often considered an indicator of alcohol-related liver disease, but is also found in Wilson disease, early-stage acute viral hepatitis, and hepatocellular carcinoma. Since AST is an enzyme non-specific for the liver, an elevated AST to ALT ratio with relatively normal ALT levels indicates extrahepatic causes. Liver biochemistry abnormalities can generally be classified into hepatitic or hepatocellular and cholestatic patterns. A hepatic pattern is marked by a predominant elevation in liver transaminases, indicating hepatocyte damage. This is commonly observed in viral hepatitis, alcoholic liver disease, and autoimmune hepatitis. A cholestatic pattern, on the other hand, is characterized by a disproportionate elevation in alkaline phosphatase ALP compared to transaminases, suggesting impaired bile flow. This can result from bile duct obstruction or intrahepatic cholestasis. The R ratio has been introduced to differentiate between these patterns, particularly in cases of drug-induced liver injury. The R ratio is calculated by dividing the patient's ALT level as a multiple of its upper limit of normal by the patient's ALP level as a multiple of its upper limit of normal. An R ratio greater than 5 indicates a hepatic pattern, less than 2 suggests a cholestatic pattern, and between 2 and 5 represents a mixed pattern. This ratio assists clinicians in determining the likely cause and guiding further diagnostic evaluation and management of liver dysfunction. As expected, the R ratio in PBC is predominantly cholestatic, whereas autoimmune hepatitis and hepatitis C are mainly hepatitic. However, a significant number of cases of hepatitis B, alcohol-related liver disease, and non-alcoholic fatty liver disease exhibit cholestatic patterns rather than hepatic patterns. The R ratio should be interpreted cautiously as it is most accurate for acute or active liver diseases showing their typical targeted injuries. In inactive diseases with relatively normal liver enzymes, R ratios are usually below 2, inappropriately categorizing them as cholestatic patterns. Many patients with hepatitis B in my cohort received antiviral therapy and had relatively normal liver biochemistry. Therefore, it is not unexpected to find their R ratios falling into the so-called cholestatic pattern. At the start of our lecture series, I introduced various special stains used for evaluating medical liver diseases. To conserve liver biopsy tissue, minimize unnecessary costs and storage requirements, you may consider reducing the number of stains used. So, which stains should be routinely included as a minimum? Routine liver biopsy analysis should include 2 levels of H&E, a reticulin stain, an iron stain, and a PASD stain. Although the connective tissue stain can be substituted by the reticulin stain, I strongly recommend including one. The Oursine stain is optional and can be requested specifically for suspected chronic cholestatic conditions and Wilson disease. Additionally, having an extra level of H and E is often very beneficial. The PS stain has very limited value and can be omitted. The sequence in which one examines slides in a liver biopsy panel often comes down to personal preference. For trainees who are less familiar with medical liver biopsy, it's advisable to start with a connective tissue stain to detect any signs of chronicity. Following this, the reticulin stain should be reviewed to confirm the connective tissue findings and assess for architectural distortions like collapse, twin cell plates, and nodular regenerative hyperplasia. Next, examine the iron, Oursine, and PASD stains for abnormal intracellular deposits. Finally, the H&E sections will be systematically reviewed to identify relevant pathological changes and conclude the histological pattern. Since the H&E stain can reveal a wide range of pathological features while special stains highlight specific, limited features, it may be easier to start with the special stains before examining the H&E sections. Just a final note, there is no need to examine liver biopsies at high magnification. Using a 10x or 20x objective is sufficient for most examinations, except when reviewing the Orson stain.
This is not the end. It is not even the beginning of the end. But it is perhaps the end of the beginning.
Here's a quote I love from Sir Winston Churchill. Finishing the examination of liver biopsy slides is really not the end. Correlating clinical and pathological data is essential for medical liver biopsy, a point I have stressed throughout these lectures. Always revisit the request form to ensure that our histological diagnosis aligns with the clinical picture and addresses the clinician's query. If possible, I also check the electronic patient record to review clinical notes, laboratory tests, additional investigations, and medication history. Examining the trend of liver biochemistry over time is more insightful than depending on a single snapshot provided on the request form. Feel free to directly discuss challenging liver biopsy cases with your clinicians. This collaboration can help you arrive at a more clinically relevant diagnosis, ultimately aiding in the patient's management. Direct messaging is a good alternative nowadays, especially when your clinicians are busy. However, always ensure compliance with your hospital's privacy policy regarding patient information. Multidisciplinary team MDT meetings are immensely valuable, and I have always found them to be enjoyable. As pathologists, we are essential members of the team dedicated to supporting our patients. Additionally, understanding the clinical presentation and management plans of patients can refine our diagnostic approach, leading to more clinically relevant pathological results and promoting a holistic perspective beyond just examining slides under the microscope. These reference books are crucial for the entire series of lectures. They provide comprehensive information and serve as essential resources throughout the course. Thank you for accompanying us through the entire series on essential medical liver pathology. I hope that the information provided has been both enlightening and useful for your clinical practice. Your commitment to learning is highly valued. I will keep creating more videos on liver pathology. If you found the content beneficial, please subscribe to this channel and share your comments or questions. Your feedback is crucial and aids us in enhancing my future content. Thank you for your support and for being part of this educational journey.